Okay. Well, good afternoon, folks. Thanks for joining us for lunch. It's always a pleasure to be here, certainly under different circumstances today and different environment, but I'm glad to be able to be sharing this with so many of the folks out in the community. We'll go back to the main slide here again. This is a general talk on medical ethics in the community. And what we really tried to do to make this practical is try to use some case-based examples, both from clinic as well as from hospital-based medicine. And my hope is that we could use Poll Everywhere to try to get folks that are not on campus here to be able to answer. That may not happen, but that doesn't mean we'll still get to have the fun. And since there's a whole bunch of people here, I will purposely just be able to look at them and see if they have any thoughts about things. So I don't have any relevant disclosures. I do work at VA and at the the VA here in Birmingham and UAB. And we're going to talk about, again, a framework of looking at ethical situations, trying to think about the main principles that kind of govern how we make decisions and how we face difficult ethical dilemmas in clinical practice. So we'll talk about some that involve end of life, some that involve legal, some that involve just all throughout the course of people's illnesses, and try to approach some of those. And this is something that I've used well before COVID was around, so I don't have any COVID cases, and I hope in a way that's actually a good thing. It's a little bit of a respite from having to answer questions about COVID right now. But I think some of these situations certainly are applicable. So looking at Beauchamp and Childress's approach to clinical ethics really focuses on 4 principles. The principle of beneficence. You know, why did we go into medicine? We went into medicine to do good, whether you're a nurse, whether you're a social worker, whether you're an advanced practitioner, whether you're a chaplain, you want to help people. And that's really what beneficence is about. When we think about non-maleficence, it's really how we want to make sure we're not hurting patients. And a lot of situations right now, this is really challenging. It's always challenging, but particularly during this time when people's conditions are changing so rapidly. And, you know, we see folks that might not have been on certain treatments or might not have been offered certain things, but are receiving them right now. I think that's a particularly challenging situation to be in. How do we not hurt people but give them the best chance to get better? We want to respect people's autonomy. And one of the real challenges at this point with autonomy is we want to respect what their autonomy is, but we also know that people are not individuals that aren't impacted by their community or their loved ones. And when we're trying to make situations known with patients' families not being physically present at the bedside, this becomes particularly difficult. And then again, about justice. How do we make sure that we're acting justly? And again, when people develop rapid respiratory failure, we talk about ventilators, we talk about ventilator rationing and who should get ventilators, who should be getting ECMO or not getting ECMO. And these are really policy level decisions. They're not at the bedside. Our goal at the bedside is to take care of the patient who's there with us. So really, we look at beneficence, non-maleficence, and respect for autonomy as the big 3. And then thinking about framing that within the concept of justice is important as well. One of the real challenges is that we want to do these. I'll often ask rooms of people, what do you think the most important one is? And get various different answers. But the real challenge is they're often at odds with one another. And one specific principle isn't necessarily trumping another situation in all certain situations. So there are times when the issues related to doing good for the patient outweigh the potential harm. There are situations where we want to respect autonomy, but we have to do that within reason based on the limitations of what resources we have or what's available. So we're going to start with a case. And again, folks, if you're watching this, if you're here, I'm not going to make you hold up specific signs here. I'm hoping that the first 25 people will be able to vote, but again, if not, we will adapt as we've learned to adapt for the last several months. We're thinking about a 72-year-old gentleman here. He's alert, but his mini-mental status is diminished, so he's somewhere cognitively impaired. And he has a liver mass, and basically, as a clinician is recommending a biopsy, and the patient agrees to the procedure of a biopsy, he can tell you the basic risks and benefits associated with that. So in this particular situation, what would we want to do? Would we feel that we would proceed with the biopsy as we have adequate informed consent? Would we feel like we would want to do obtain a surrogate because the mini-mental status is low? Would we want to get psychiatry involved to make sure that the patient has capacity? Or would we want to consult our legal colleagues for advice? So someone voted, so there must be somewhere that it's happening, and I don't think it's me. So someone wants to get a surrogate, but we'll give about 10 seconds for folks. And again, it's always going to be the website at the top here, that if you're joining us late, just feel free to go to that website and the questions will pop up. So in this particular situation, we think that folks would say, you know, he has cognitive impairment, we probably should get a surrogate. And one thing that I might challenge in this situation is, you know, what is our bar for saying that someone's been informed and our understanding of them being informed? So I might argue in this situation that we have informed consent for this particular situation, and that's mainly because of how do we stratify based on the risk of a procedure. So when a patient needs to make a decision, we have to think, is it something that is fairly safe and effective and they could articulate the basics of what's going on? So again, safe, effective treatment. You know, it's different if someone comes in and we're thinking about antibiotics. You know, we don't necessarily go through the whole risks, benefits, alternatives about starting Augmentin or amoxicillin for somebody. So basically, if the patient's aware of what's going on and they assent, that's generally acceptable for safe, effective procedures. If we have less certain treatment options, those that deal with more uncertainty really have to do with understanding what the treatment options are, and there really has to be some capacity to be able to choose or reject based on what the risks, benefits, and alternatives are. And I might argue in this situation, again, something that's not very routine, maybe if we were looking at a brain biopsy, something that's a little bit higher order, we might say, does he really understand what he's getting in for, without just telling us what the basic risks are? And then for very dangerous treatments, when we're talking about ECMO, when we're talking about left ventricular assist devices, when we're talking about stem cell, when we're talking about transplants, these are very, very challenging treatments. There's multiple layers in terms of the psychosocial factors that might be influencing whether someone's able to understand. They may want a transplant, but are they really able to handle the things that are associated with that? So we have to be much, much more certain in that situation. So I might argue for, you know, straightforward things, and again, everyone has a different level of comfort what that means. Basically, a lot of patients can say, hey, I think I have cancer. You're going to take the biopsy and see if I have cancer or not. So in that situation, that generally is acceptable. Even if the person can't balance their checkbook, even if the person can't necessarily be subtracting things. So I might be okay with letting this gentleman go with this procedure in this situation. There are exceptions to where we don't need to obtain informed consent. If it's an emergency situation, certainly we proceed with what's medically indicated. Patients can have the right to waiver, and in this particular situation, we see this not uncommonly where patients might be like, you know, I really don't want to talk about this. Let my son talk about it. You know, talk to him. I really don't want to know. I turned it over to God. In that situation, we should respect their right to not receive. We should not be battering them with the information, and we'll have a case that demonstrates that a little bit more later. If someone is incompetent, which again, competency is a legal concept, judges and other folks, guardian ad litems get appointed for people who are incompetent, as opposed to decision-making capacity, which is really a clinical decision that any clinician can determine whether the patient has capacity. Capacity tends to change over time, as opposed to incompetence tends to be related to something that's a bit more permanent. Therapeutic privilege is a situation where we would withhold information and not tell the patient what's going on because we're worried that it would be so devastating to them to know what's really going on that we're protecting them. And I think Marcus Welby probably got away with this in the 50s, but in our society of folks that have iPhones in their pocket and are Googling what the diagnosis is, it's really hard to argue that you're going to be able to withhold that information from a patient. And if you feel like they're imminently a danger, it probably needs to involve mental health. So let's start off with a fairly easy one. I think most folks feel comfortable with case 2. This is a situation where we have a 61-year-old female. She practices, she's a member of the Jehovah's Faith community, and she has life-threatening epistaxis. She cites religious beliefs and says, I do not want a blood transfusion. So looking at our options here, what are our options here? Is it, would we consider potentially transfusing her despite her refusal? Would we obtain a psych consult since the refusal seems somewhat irrational? Would we respect the decisions and treat her without a blood transfusion? Or would we advise her to seek treatment elsewhere? Do they pop up for you? Okay, good. If they don't, just give me a no and then I'll know. But we'll give a few seconds for folks here and afar. So the majority of folks are saying we should respect her wish. And actually I jumped ahead, and that's why the question is probably a bit confusing. We should respect her wish and not transfuse her. The next case here was going to be really about what to do about a child. And if the person's an 8-year-old child, what would we do in that situation? We feel pretty good if the person's a person who's 61 and an adult and has decision-making capacity and legal, but if we're looking at a child here who's 8 years old, and this got pushed together in the translation here, what would we do for the 8-year-old child and how might that be different? And sometimes that's a little bit more troubling. 8 is an interesting age that I picked. And part of that is because when we think about religious beliefs and medical decisions, the issue really comes down to respecting patients' autonomies. And patients can have beliefs that influence their preferences, and they don't have to agree with what our beliefs are. That doesn't mean that they're necessarily irrational. So there are folks that might say, I don't want to do chemotherapy. And we might have an oncologist who says, but this is very treatable breast cancer with favorable receptors. Why wouldn't you do treatment for this? And we know, particularly here, a lot of folks might not want to do that. And it may be based on their beliefs, but those beliefs don't necessarily say that they don't have decision-making capacity. And we really should respect those beliefs. One of the main things that we need to do as clinicians is to respect and negotiate and not abandon with our patients. If we don't know what their preferences are, if we don't have clear evidence, we do treat, because that's an emergency situation. And then one of the questions a little bit, again, with the children conscientiously objecting, what does the law tell us about that? And the law tends to tell us with children is that we have to err on the side of life. And the courts almost uniformly will say that if there's a minor who's involved, that's someone who should be treated regardless of what the parents' wishes are, and that's based on the precedent that's been there. So again, there's lots of other groups that might have certain preferences about not receiving chemotherapy because it's toxic. Other folks right now with coronavirus, we're seeing a lot of different beliefs. Where it becomes a little bit more challenging is when we have teenagers, when we have folks that might have within their church community said, I believe, I agree to this is what I want, and gone through some sort of confirmation or baptism process or indoctrination or ritual that goes along with that. And even though they're under the age of 18, they say this is not consistent with what my beliefs are. Courts tend to be more sympathetic in that situation and look at things more carefully on a case-by-case basis, but the general precedent is err to save the child's life. Okay? So let's look at case number 3. This is a 61-year-old woman. She has metastatic breast cancer and she's hospitalized for pain control. She had been involved in home hospice. Her pain's not controlled, so our morphine drip is started at 2 milligrams an hour, and the patient dies several hours later after being admitted. Her respiratory rate was highly irregular and just 4 breaths per minute just prior to the time she died. What do we think best describes what happened here? Is this an example of euthanasia? Is this an example of physician or medical aid in dying? Is this an example of a medical error that occurred, or is this an example of palliative care in this situation? And generally in this situation, most folks would say that sounded pretty reasonable to me, 2 milligrams an hour. That sounds like that would be what we would do. Well, what if you were really worried about the person and they came in and you said, let's just be sure we're going to start 20 milligrams an hour? I saw some shakes of the head that others couldn't see. So why does that feel different? Again, what is our goal? What are our intentions? And that's really what Thomas Aquinas posited in his 13th century Summa Theologica to try to talk about this doctrine of double effect. And double effect really comes down to looking at something that might be helpful but might have a harmful consequence that's unintended. So his example was, is it ever justifiable to kill somebody in self-defense? Right? So that was his in the 13th century, that was his justification. But we apply it to, is it justifiable to give patients medications that might slow down their breathing or have adverse side effects? And really, there's these 4 criteria that need to be met. And I could read them, but you'll have the slides and I often stumble over them. But one way that I try to break it down into 3 very clear points is, what is your intent? What is proportionate? And what is the marker of success of the intervention? That's really what he's saying, but he's talking about good and good effect and bad effect and undesired effect. So let's think about it this way. So as the clinician writing for this, what's the intent? Well, we only know what the intent is within our own hearts. We can try to be as transparent about that, and generally, if I have a reason for starting somebody on 20 milligrams an hour, usually someone's going to question that. I'm going to say, my intent is this because they've been on methadone, 200 milligrams at a methadone clinic, or their heroin abuse makes me use this. But generally, my intent has to be that to relieve suffering for the patient. What's proportionate response? Well, that's picking the treatment that would be appropriate given the patient's profile. So what are their goals? What are their symptoms? So for metastatic breast cancer, the goals might be comfort, and we might accept those different types of risks associated. And the truth is, we're not even really sure that using opioids does shorten end of life. There's been lots of studies that have looked at palliative sedation, where we sedate folks to allow for natural dying without pain, and that they don't die necessarily any quicker than the people who didn't get those medicines when matched. And again, how do we mark what the success of the intervention is? Well, it's not that the patient dies, it's that the goals of care should be met by using the sedation or the treatment. So really we want to make sure that it's clear what I'm doing, I'm picking a dose that's appropriate for this patient who's here, and my marker is going to be that they're going to be comfortable. And where we see this sometimes as a challenge in our situation is, this can be distressing for families sometimes. I think a lot of folks say, hey, Dad's going to stop dialysis, we're going to focus on his comfort. Dad comes into the hospital and 5 days, 6 days, 7 days, 8 days, 9 days, and kind of like, well, I thought if he stopped dialysis he was going to die. Well, the median number of days that someone survives after withdrawal of dialysis is actually 9 days. So I think a lot of folks think, well, what is that going to be? You know, are we going to be shorter than that? Or for the acute care setting, it might be I'm going to take them off the ventilator and then Dad's just going to die, or I'm going to stop the pressors and my loved one's going to die. And I take care of a lot of folks who stabilize off of their pressors and off of the ventilator. I take care of a lot of folks in the outpatient who do things like stop insulin or stop other types of treatments because of advanced dementia, folks who are at home who stop feeding tubes because it's not consistent with their goals, or they're having infections and aspiration. And again, that doesn't necessarily mean they're going to die quickly, and that could be morally distressing to those that are caring as well as those that are our loved ones. I think one of the other things I just want to mention here again is, we'll talk a little bit about aid in dying just from the example, and again, not as a proponent, but simply to be aware that as we're within different states. Now, I'm aware within, Catholic healthcare systems, again, even in states where aid in dying is something that's illicit within the Catholic healthcare institution, and that's consistent with the ethical and religious directives of the Confraternity of Bishops. But I will bring that concept of proportionality up in a later case. So let's go with one that seems pretty minor in terms of the conundrum. So 63-year-old, widespread metastatic cancer, sepsis, now in a coma. His advance directive states that he did not want life-sustaining treatments initiated or continued if the chance of recovery is small. And the family says, those IV fluids, he said he just didn't want those. Why don't we go ahead and stop those IV fluids? So if they're saying that, in this specific situation, what would we do? Would we feel comfortable just saying, okay, that seems reasonable, we'll stop the fluids? Would we say, well, I don't necessarily have to do this because hydration is not really a medical treatment. It's nutrition and hydration are separate. Would we say that we should get our ethics consult involved because we're not sure? Or should we just say, no, I'm not going to do that because you haven't provided me with clear and convincing evidence that he would want us to stop these fluids? Okay, so see a little bit of a mix here, and I think the fluids we started off with just kind of the lesser of the more common, looking at more along the lines of what is artificial nutrition and hydration, how do we look at that as a medical treatment. Let's look at a similar case, okay? Same guy, has an advance directive, says he doesn't want advance directives. He's on pressors right now, he's intubated, he's still hypotensive, he's having runs of VTAC. But the family says, I know what his wishes were, but I really want everything done because I want a miracle. Give him the chance at a miracle. So in this particular situation, should we just say, no, we're going to stop all treatments and allow death to occur? Are we going to ask ethics for help? Are we going to refuse to comply with the family since there's no clear and convincing evidence to do that? Depending on the state I work in or hospital policy, it says depending, but it should say depends on state I work in or hospital policy. Or I won't pick one because I'm just not sure. So now we're talking about folks who aren't saying things in accord with the patient's wishes. We're talking about folks who are talking against what the patient's previously stated wishes are. So this is one of those, what's the role of a surrogate, what's the role of surrogate decision makers, and what do we allow them, how do we process when their wishes are not in line with what the patient's wishes are. Okay, last one, and then we'll break it down. This is a different situation. This is a gentleman who has COPD and dementia. He's in your clinic. Okay, so this is for our ambulatory folks that might say this is too much inpatient sweats. So he's out in the geriatric primary care clinic, and basically you're the clinician and say you don't think that this person is going to do well with hospitalization or aggressive care. And basically the wife says she wants everything to be done, including admission to the ICU and ventilation. So for this patient, are you going to hospitalize and proceed with aggressive life-sustaining treatments? Are you going to request ethics consultation again? Are you going to are you going to transfer the patient to another facility or institution? Or are you going to unilaterally place a do not resuscitate order? Or are you so worried that this seems so abnormal and out of character that we're going to request protective custody for this patient? What are we going to do? The gentleman with advanced dementia, you're not thinking it's going to be helpful, but the wife says, hospital it is. So most folks are going to say, hey, we're going to do hospitalization. So let's talk about surrogate decision making in general, what's allowed, what's not allowed, and what makes each of these cases different, and we'll break it down a little bit. I think people often talk, well, in America we talk about anything these days and usually disagree with one another, but I think one of the big arguments about looking at end-of-life issues is there's always been this notion that patients have a right to die. That is absolutely categorically not true. Patients never have had a right to die. They absolutely have a right that's guaranteed by the Constitution to be left alone. They have the right to refuse to have treatments or the right to request that life-sustaining treatments be stopped if those treatments are not consistent with their goals, values, and preferences. And if a patient is incompetent or lacks decision-making capacity, then those patients still have the same rights that are executed through a surrogate. And sometimes those surrogates are guided by legal documents, advance directives, and sometimes those surrogates go off their own beliefs. But really it's about how do we make sure that we understand what the patient's wishes are. If there are not surrogates that are available, there is a hierarchy for who makes decisions when patients can't. The courts want nothing to do with these cases for the most part. They heard most of them through the 80s and 90s and basically said no case has to go to court. Mainly because they articulated in a few cases that first, there's not a difference legally or constitutionally between withholding and withdrawing medical treatments. Okay. Artificial nutrition and hydration, a lot of people talk about ordinary or extraordinary care, particularly in the Catholic ethical directives. But again, artificial nutrition, artificial hydration are medically administered treatments. It's not the same as someone drinking water out of a pitcher. It's not the same as someone eating a meal. These are medical treatments that require medical expertise to undergo. And you say, well, what if we're doing blenderized tube feeds? Well, someone had to put that tube there and has to manage that tube feed and its potential complications. And basically, if we're talking about a right to be left alone, physicians are generally not held liable for holding things in accord with patients' wishes. But that doesn't mean that if we're talking about requests the other way, that there might not be liability. So one way we've looked at this in the past is said, well, what are some of the differences between withholding and withdrawing a life-sustaining treatment? What are the differences with using comfort care or palliative sedation? How is that different from physician aid in dying or euthanasia? And when we look at this, the withholding of a treatment is really saying, we're not going to do this because it's too burdensome, and we're going to allow the person to die of the underlying disease. So that's, again, the right to be left alone. That's legal in all the states. When we're holding about withdrawing a treatment, that's, hey, he tried dialysis, he tried chemo, it's just not helping. The ventilator, he's not getting better. It's okay to remove that, and that overall, again, is allowing for death from the underlying cause of disease to occur. A lot of folks have questioned about palliative sedation and comfort care, but when it comes down to it, the goal, again, what are our goals? It has to be unambiguous that our goal or our intent is to relieve symptoms and to allow the person to be comfortable and pass away from the underlying disease. Now, where it gets tricky is the whole medical aid in dying, physician aid in dying, and that really has to do with something where an intervention is prescribed for a patient to use, where the intent is somewhat a little bit more unclear. Some would say it's to terminate the patient's life to avoid the suffering. Some would say it's to avoid the suffering, period. It's not any different. But the real issue from previous is it's a proportionality concept. There's a difference between taking one barbiturate capsule to be comfortable and taking a bottle of 100 with a different purpose. So in this particular situation, this is not legal in Alabama, and Alabama is one of the few states that has actually gone ahead and put forth legislation to not only say that we're not going to do this, but we're going to criminalize physician aid in dying in the state of Alabama. That bill kind of languished a little bit and didn't really go anywhere. But it's important to know that according to the ethical and religious directives for Catholic healthcare, that the withholding and withdrawing of life-sustaining treatments is absolutely permissible, including that of artificial nutrition and hydration. There's a lot of misunderstandings about ERDs, and sometimes folks get into one of the cases we talk about later where I have to have a feeding tube, or I have to intubate dad, or I can't not put him on the ventilator because that's going against the teaching of the church. And being part of Ascension, being part of the ethical religious directives and under the auspices of the Confraternity of Catholic Bishops, the teaching again is that no one has to undergo a treatment that really essentially is not allowing them to live the life that they believe that God intended them to live and to give glory to God. That's the gist of it. People can look at it, ERD 78 and others within that section about care at the end of life. But withholding and withdrawing of life-sustaining treatments is something that's absolutely permissible, and there's no teaching that says we have to do all these things. Now, that doesn't mean that some people aren't going to come in and want all of those things. That's where it really becomes, well, what's right? From a resource perspective, what's right? So what about the person who has an advance directive? And again, the first person with lung cancer, and the family asked and kind of wanted to go with and against, did have advanced directives, and that's really something that comes into play for someone who does not have decision-making capacity. So I'm very careful when I talk to patients about making sure that they understand that as long as I can talk to them, I'm going to talk to them. If I can't talk to them or they can't tell me what their wishes are, then I'm going to go to either a written document or a loved one. In other situations, sometimes we would look at whether there's a power of attorney for health care that's either legally appropriate or one who's assigned by a document. And what it's important to remember surrogates about is this really should be a document or a decision-making process that is a full extension of the autonomous person. That basically, if that person was here, Tim Quill, interestingly, a proponent for physician aid in dying, but probably most beautifully articulated what a surrogate's job is to do, and that's to say, if your loved one could sit here right now in that chair that's socially distanced to my left, and know that they were in this situation, and that in 15 minutes from now they had to go back to that situation, what would they tell us they want? And many times we'll hear, Dad never wanted that. Dad would never want this. And then you say, well, why are we doing this? And then the surrogate says, because I'm not ready to let go. Well, the job of being a surrogate is to carry out what the patient's wishes are. So that's where, hey, how can we offer resources? How can we offer counseling, bereavement, other things to say, your loved one cared about you that much that you don't have to make that decision. They've made that decision for us. Now, it's more challenging once we start treatments and have them ongoing to say, can we stop those treatments now because we think they're not beneficial anymore? And legally, particularly in Alabama, we don't have a mechanism for stopping treatments just because we don't think they're beneficial anymore. It comes back to respect for autonomy trumping what we might see as non-maleficence. So the Patient Self-Determination Act of 1991 protects a person's rights to make these decisions. And this is where I urge all our folks in the community, in the outpatient setting, asking folks about these preferences when they're really sick is not a good time in the hospital. So a lot of my folks who have COPD that's advanced, who have cancer, March we had a lot of teleconsults about COVID is going around. How do you feel about if you were to get sick with this? And most of them were like, I wouldn't make it if I got it. And it's like, oh, let's make sure that what your wishes are line up with that if you do get this, that we're not sitting there doing ECMO for someone with widely metastatic cancer that's not having any hope of getting better. Let's make sure we're not having someone intubated and unable to be weaned when we know that even a disease less virulent and devastating than COVID, they're not going to get off the ventilator if we do that. So it's a reminding situation where surrogates really need to remember that they should honor the advance directives. So for that case where we talked about the patient saying, I don't want all this stuff, I'm in multi-organ system failure and getting VT and on pressors, it's really about working with the family to say, this is not something that is consistent with what the patient's previously stated wishes are. Let's talk about that. Let's continue to revisit this. What if the patient doesn't have an advance directive? Well, that's case 5. Case 5 does have a situation where we have a young person, 41, who's in a persistent vegetative state due to an anoxic brain injury. She does have an advance directive, fortunately, and she says that her parents are the surrogates. Her parents say that basically she would want everything done. But her husband, who's married to her husband, says, nope, withdraw the feeding tube. This is not consistent with what she would want. Go ahead and stop the feeding tube. So in this situation, who's the appropriate surrogate for this patient? Is it the husband? Is it the parents? Is it a consensus of the husband and parents? Given the conflict, there's no obvious surrogate, they should go to court? Or I need to know where the case is so I know what the law says. Okay. We have some folks going with the husband. And before I move forward, I'm going to go back. And I'm going to say, highlighting here, the person basically has an advance directive that names her parents as surrogate. And then I'm going to go back 2 slides and say basically advance directives are legal extensions in all 50 states, including the District of Columbia. So I'm going to answer this particular question, B, because the person has an advance directive. Now, if they didn't have an advance directive, that's a different situation. So we're going to talk about that different situation. And if they didn't have an advance directive, the answer would be, I'll let my 3 people here who are going to say it out loud. I won't look at them though, so they're not nervous. What are you going to say, husband? Okay.
If you didn't have it.
I'm going to say E. And you're going to be like, what? And it's like, yes. Why did I say that? Because I have something to teach about it. So we're going to go with E. I need to know where state it's in because it does matter from state to state. So if someone can't make a decision and does not have an advance directive, the highest order of surrogacy is if the court says who your surrogate is. So if they don't have, and the court says, I believe, I have a young gentleman who has a brain injury now after an accident. My goal is to have his parents where the court say they are his guardians, they are his surrogates, they will make all medical decisions for him because he's not going to regain that issue. Now, some people can have an advance directive that's appropriate and they would say who their loved one would be. The courts rarely are going to trump this. The only time a court might go in there and say, I need to appoint a surrogate, is if they really worry that that person named in the advance directive is harming them, financially exploiting them, physically harming them, doing something like that. But if we don't have a court case, because in Alabama it takes, a couple weeks, couple months to get someone to answer the phone, let alone have someone point it for them, and they don't have an advance directive, it really goes state by state. And we mentioned again that, the advance directive is in instructions. It's the fully extension of a fully autonomous person. It's legal in all those states, but if they don't have that advance directive, what do we do? And basically, this is what we do. We look at, and no one else is here, so people on TV are going to look at this map and say it's great. And then I'm going to say, folks, when we're done, can you see it anywhere? You can see it there? Okay. So it looks like a checkerboard quilt, right? So the state of Alabama is a blue state on this map, and that says that surrogate hierarchy does exist, must go to court to challenge a surrogate authorized by statute. So that's where the state of Alabama has said spouse. Spouse trumps parents. Now, what are the situations where things are different? I practiced in Minnesota for a long time. Forgot to change one of those slides. Surrogate hierarchy exists, but only applies in certain circumstances like research, mental health, or other situations. So I had plenty of people who would come in and be like, yes, I want an aortic valve replacement. Well, who's your surrogate? Well, I don't have an advance directive. Okay, who's going to make decisions? Well, I really don't want to assign somebody. No, that's where mom and dad and daughter and common law wife and all these folks start not getting along, and we deal with struggles. So Alabama is a state that has a statute. Some of the things to be aware of are the VA. So I practice at the Birmingham VA. Where does the VA fit? The VA does not fit Birmingham. The VA fits the VA's federal domain. So the Veterans Health Administration has a list of who the surrogates are, and they're similar to, but not exactly the same as the state of Alabama. So if someone's under care at a VA facility, they follow the federal. If they go across the street to UAB or down the street to St. Vincent's, Maine, you're back in Alabama again. But if they leave St. Vincent's, transfer over to Birmingham VA, they're within the VA domain. So it follows the VA hierarchy for surrogate decision. Okay? Let's take a look at one more case, and then we'll go back to some of these challenges about, because we could talk about surrogates a whole long time. 61-year-old woman comes in with bright red blood per rectum or hematochezia, anemia. You're concerned that the person has colon cancer. You're recommending a colonoscopy. The person does not speak English. Her son demands that you not use the word cancer, because they claim that in their culture, parents are not told bad news. So bright red blood per rectum, needs a colonoscopy, worried about cancer. Son says you're not going to talk to her about cancer. So what do? Through an interpreter, do we discern the patient's desire for information? Do we comply with the son's demand? Do we proceed with the colonoscopy, and if cancer is found, use obtuse terms to describe the findings? Or do we refuse to comply with the son's demand and tell the patient the information? Okay, so most folks are going to say, I'm good with this. I'm going to use the interpreter, which may or may not be in person, which may or may not be readily available. And then the urge is, well, we'll just use the son or a family member. Well, that's the challenge of cultural competency and trying to understand these things. So what are some of the challenges about truth-telling and release of information? Again, we tell people the truth because we want to respect their autonomy and we want patients to make informed decisions. Again, patients have an absolute right to say, I don't want to make those informed decisions. I want my son or daughter or neighbor or consensus of interested parties to make that decision for me. But that doesn't necessarily mean that in the particular situation that they still don't have goals that want to be met. They still want to be informed, they just want those who are making decisions for them. So we have an ethical and legal obligation to tell the truth and disclose information. So first, let's look about mistakes before we get into the culture part. What about telling people about mistakes? And this is an old study, but the teaching still bears out. When people know that mistakes were made, virtually all of them want to know that a mistake was made, even if it means, hey, you got 2 grams of ampicillin instead of 1 because the pharmacy sent the wrong bag up, or you got an extra dose of insulin. Basically, they want that because they just want to know that it's not going to happen again. And that's what we'll talk about on the next slide. Patients really want to know what to do, and they're more likely to consider litigation if they're concerned that this was not disclosed to them, or that it's being swept under the rug, or again, if there's real issues about trust. And again, in Alabama, there are huge inequities in terms of our healthcare system. There's racial inequities, there's socioeconomic inequities, and again, sometimes it's very easy to go into those unconscious biases about, are we going to tell this person or are we not going to tell this person? Or it's very easy for people to say, in the past I've worried about this and I worry about it now. So you could see why honesty is super important in this situation. And honesty is basically, for this particular patient, from a cultural perspective, really is about respecting that individual's right to information in this country, in this state, but also recognize that culturally, spiritually, that there are some folks who just don't want that information, and that patient waiver is completely appropriate. So the way I generally approach this is, again, I'm concerned that there's a medical problem going on in your colon. It could be something very serious. We'd like to do a test. Those results could be, worrisome things. Is that something that you want to know details about, or are you the kind of person who wants to know details about your health care? Are you a big picture person? Do you want us to work with someone else to make those decisions? I can tell you a lot of people will say, talk to my son. A lot of people. And in that situation, it's completely appropriate. You've respected the patient's autonomy. But where we run awry is we make assumptions. We make assumptions about people's upbringings, we make assumptions about where people are coming from, about their educational level, about their culture, and that's where we get into trouble. So I tend to be very, a lot of people will say, as a palliative care person, how long does mom have to live? And mom's laying right there. First thing I say is, is that something, that's a very important question. Is that something that is helpful for you to know? Or is that you're a big picture person who just wants to take each day as it comes? The majority of people will say, big picture, day as it comes, don't want to know. Then, do I have your permission to talk to your loved one outside about what some of my concerns are? Yeah, you could talk to my son. Then I could go say days to weeks, weeks to months, months to years. But to just say, oh, he's got months. Well, you don't want that information. Again, so we don't, as Edmund Pellegrino would say, that truth-telling here, thrusting truth upon a patient who delegates, is gratuitous and harmful misrepresentation of the moral foundations of respect for autonomy. Because again, our job as clinicians is to see what's important to you. So when I practiced in Minnesota, there were lots of different groups that I had never taken care of. There are a lot of Somali immigrants in Minnesota. There are a lot of Hmong immigrants in Minnesota, and they each have their own traditions. As someone who was practicing at a Catholic hospital, St. Mary's, but had a lot of Muslim patients who were from Somalia or from the Middle East, again, I can't be an expert in all of these things. So from the legal and ethical perspective, it's really about being culturally humble. It's about saying, I don't know about this. Tell me about what's important to you. And I think that we use this from culture to culture, but I think it plays a huge part in our community. And as a soapbox, I think it's a huge problem with a lot of us. We don't want to know about other people. We just want to make our own assumptions. But this is a real time where we could learn a lot about other people and not make assumptions that given where they're from or what they look like or what they believe or what their income is, that they have certain beliefs or not. It's just an opportunity to really try to explore those. And cultural competency is a much higher and lofty goal at an institutional level, but we can't be experts in everyone's background. And that's why I think it's just important to know what's important to that patient, what's important to that family of a given patient. Okay. So I think, again, good communication. When we think about ethical dilemmas, the first paper I ever wrote a long time ago as a resident, looking at a couple hundred ethics consults, the majority of them had nothing to do with ethics. They had everything to do with communication. Someone told me something I didn't want, someone wouldn't tell me, someone wouldn't disclose that mom's prognosis really was really, really bad, and just kept saying, it's okay, we'll see it tomorrow, it's okay, we'll see it tomorrow. Not really ethical issues, just struggling to communicate about difficult situations. Legal can help. It's good to know, and particularly in a Catholic healthcare system, to at least be aware of the ethical and religious directives for Catholic healthcare and what they say. There is nothing, the one case I gave was kind of the opposite of Shivo, to mix things up, where Shivo's husband was very clearly the person who would make decisions by Florida law, and she did not have an advance directive. So even though the parents disagreed with the husband, legally the husband was very much the surrogate decision maker. But one of the things that came out of that is, well, someone who's in a persistent vegetative state and having a feeding tube, and where that gets misrepresented is mom has severe Alzheimer's and metastatic breast cancer and she has to have a feeding tube. No. It does not say that you need to start a feeding tube in the ethical and religious directives. It says that care should be provided to the patient that's proportionate to what their goals and values are, and that no one's legally obligated or morally obligated to receive IV fluids or artificial nutrition hydration if it's not going to be something that's going to change their overall outcome. And that's a real summary of it, but they're freely available on the website for the USCCB. And that's something that you're probably at your Ascension website, you could probably find them printed somewhere. But working in the Catholic healthcare system, it's good to know about these things. So with that, I really thank us for the opportunity. I thank us for working through the Power EV, and I know there were more than 3 responses, so thank you to anybody on main campus or in a clinic or satellite area that was willing to try to do that. Thanks to my raucous group of 3 guests and AV expert here. Do you folks have any questions or thoughts? Or?
I was just surprised about the surrogacy and having, even if someone's married, that the parents in some state could supersede them as a surrogate.
They had an advance directive that said, I want my mom and dad.
But if they don't have an advance directive?
If they don't have an advance directive, then it's going to be, it's usually not a matter of the spouse. Usually where the differences are where it's like after spouse. Does it go to adult children? Does it go to parents? You know, it's usually not that the spouse is the number one. And in Alabama, the question is if they declared common law marriage before the expiration of the common law statute, well, that's considered spouse. So is it a declared common law or not? That sometimes would be very, very tricky in Alabama. But for the patients whose case was here, you know, it would be that their advance directive said, I want my parents to be my surrogate even though I'm married. You know, this was very, you know, a personal example. My dad was very clear. His surrogate decision maker was me. Because he's like, your mother can't talk about this stuff when I'm sick. She's not gonna say, don't resuscitate dad, he has cancer. Like, you're gonna need to do that. So even though spouse is the top, his advance directive said, I want my son to be my surrogate. So the advance directive will always trump what the legal statute is. And you're absolutely right. If you look at that paper in the New England Journal from DiMartino, if people didn't see it, that map is actually interactive on the New England Journal website. So you can go and look by states and look at Alabama, and they give you 1, 2, 3, 4, 5, 6, 7, who they are for the state of Alabama. They can give you for Pennsylvania, for Mississippi, et cetera. What they don't do is they don't give it for the VA, and that's why we did an addendum to that to say, and in the VA it's A, B, C, D, E.
I would assume that even if somebody has to say they have a advance directive, that say I'm married, I want my husband to be my surrogate. If there is that parent and that spouse that have those differing views and decide to go to court and that could always be an issue.
It always is an issue, and you know, this is well beyond the free lunch topic of, you know, I've had where a sibling forged an advance directive, you know, to say that the daughter should be the one daughter, not the wife or the other kids. I've had people that have, you know, produced illegitimate advance directives. I've had people that have misrepresented themselves as a spouse or a loved one when they really had no legal bearing. So, but that's 16 years of challenges. That's, you know, the handful cases where in 2 hands I could do that, so. Well, we are at the hour, so I thank you for being here. I thank those that were watching, and hopefully those who might watch it later find benefit from it, and I wish you all well during this very challenging and uncertain time.